Good afternoon, everyone. My name is Dr. David Millett, and I have the pleasure of talking to you this afternoon about video EEG monitoring in the setting of autism or autistic spectrum disorders. So I want to thank Lisa Ackerman and the TACA leadership for giving me the opportunity to speak with you today. And I'm going to share a short PowerPoint so that we have some talking points over the course of the next 15 minutes or so. So as I mentioned, my name is Dr. David Millett. I am the director of the epilepsy program at Hoag Hospital, as well as chief of neurological services. I have an academic appointment at USC. I want to give you just a few brief disclosures. I am not a pediatric or developmental pediatrician, so I'm not an expert in the field of autism, but I have a long experience and quite a depth of experience in reading and interpreting ambulatory video EEG studies in children and adults with autism. For the past 10 years, I've been interpreting somewhere between 100 and 250 ambulatory video EEGs per year. And I've established 2 epilepsy programs over the course of the last 15 years. These are level 4 comprehensive epilepsy centers. I'm also the medical director of an ambulatory video EEG monitoring service. There are many such services around. I happen to be affiliated with EEG2Go, which many of you may be familiar with. So let me just begin by reviewing the basics of EEG for everybody. Many of you may be familiar with it already, but the EEG is essentially a recording and analysis of the electrical activity of the brain. An adequate EEG includes sampling of the awake background activity, which typically involves rhythmic activity over the posterior or occipital head regions on the range of somewhere between 8 and 12 or 13 hertz. Prolonged video EEG studies, and in some patients, shorter ones, can often capture seizures or seizure-like episodes, such as staring spells, stereotypies, episodes of lip smacking, jerking movements, or more significant behavioral episodes. In patients that can comply with instructions, we often include provocative maneuvers, such as hyperventilation, which is what HV stands for, and photic stimulation. That's a strobe flashlight, which can sometimes bring out epileptic activity in the EEG, and in the rare cases of what we call photosensitive epilepsy, actually induce a seizure. One of the most important aspects of EEG is the sleep stage of consciousness or lack of consciousness. Sleep is particularly important for a number of reasons. Epileptic activity most often comes out during sleep. So in the majority of ambulatory video EEG studies in which we see epileptic discharges or some features of epilepsy, they appear only in sleep, and the awake background appears normal. Oftentimes the behavioral events are also normal. They don't represent epileptic seizures, but as the child goes to sleep, we begin to see epileptiform activity in sleep. The other reason that sleep is important is because there are differences in the sleep patterns of children with autism compared to neurotypical or normal children. We see changes in the amount of REM sleep and slow wave sleep, as well as the onset of sleep. Sleep is also quite fragmented. in patients with autism, as many of you well know, and the architecture of sleep, that is to say, activity over the vertex, normal sleep activity, sharp waves and spindles, can sometimes be quite atypical in autism, and sometimes demonstrates epileptic features as well. So, so an EEG really ideally will capture all of these things. Why is a prolonged video EEG recording of importance for patients that are newly diagnosed? Well, I'll get to that in the next page. So here's a number of things that the EEG tells us. Probably the most important question, oftentimes the question that parents have when they've been referred for EEG, is whether or not these behavioral episodes that their child is demonstrating represent seizures. I'll be quite transparent here. Most often they do not. So staring spells, jerks, stereotypies, meltdowns, and episodes of aggression don't typically turn out to be seizures. So but it is reassuring to have captured those during an EEG and be able to prove that it's the case. The second thing that the EEG tells us is has to do with the background rhythmic activity of the brain, whether it's normal or slow. If background activity is slow, is the slowing a diffuse process involving both sides of the brain? This is more suggestive of an inflammatory condition, perhaps a metabolic disorder, or is it focal? In which case it suggests that there's something wrong with a particular lobe or hemisphere of the brain. So that's oftentimes a developmental abnormality in the setting of autistic spectrum disorder. Finally, are there epileptiform transients or epileptiform discharges? These are brief disruptions in the electrical activity of the brain. They're oftentimes short, on the order of half a second or so. But they can be quite frequent. They can occur actually multiple times per second in extreme cases. But most of the time when we see them in the setting of autistic spectrum disorder, they're occurring sporadically once every 3 or 4 minutes during sleep. Every once in a while, we'll see a patient who has either subtle seizures or subclinical. Another term for that is electrographic seizures, electrical seizures that have no physical manifestations. Oftentimes the child may be in therapy, playing around the house on an iPad, and I will see a 10, 15, or 20-second electrical seizure, but there's really no physical manifestations of that seizure. So these are quite important to pick up, and they're more easily picked up on a long-term video EEG study. And the reasons are listed below. There's a significantly increased risk of developing seizures in autism, and a further increased risk if the EEG is abnormal. So the prevalence of epilepsy, clinical epilepsy, that is to say seizures, a seizure disorder in autism, is about 20%. And that number increases after the first seizure, and it certainly increases with an abnormal EEG. The second reason to obtain an overnight video EEG study is that abnormal electrical activity may be affecting cognition. As I mentioned, a routine EEG, whether that be 20 minutes or 45 minutes or an hour, in a clinic, oftentimes doesn't capture an adequate amount of sleep. Historically, the routine EEG is 20 minutes long. A 24-hour video EEG study will capture at least 50 times the amount of data, provides us with a lot more brainwave activity to analyze. And sometimes that 20-minute or even that 45-minute outpatient study contains no sleep at all, which, as I've mentioned in the previous slides, is really a critical component to analyzing EEG and for epileptic activity. So we know that in some cases, the abnormal electrical activity may be affecting cognition, and treatment with anti-seizure medications may improve cognition. I'll show you a recent paper that suggests that that may be the case. Finally, there's been a recent study that shows that treatment of children on the autistic spectrum who have an abnormal EEG, this may reduce the risk of future seizures and improve cognitive function. So, so these are all reasons that we want to really obtain an adequate sampling, 24 or 48-hour sampling of brainwave activity in order to determine whether there are epileptiform transients or subclinical seizures, which may be the basis for treatment with anti-seizure medications. I will just briefly touch on some of these disorders where we see very, very frequent epileptic activity during sleep. I've already mentioned that autism is a significant risk factor for epilepsy, affecting about 20% of persons with autistic spectrum disorder. There are a number of clinical conditions, diagnoses that have been associated with either epilepsy or very frequent, nearly continuous in sleep epileptic activity. One of them is Landau-Kleffner syndrome. Another one is continuous spike wave of slow wave sleep, often abbreviated as CSWS. And in these conditions, we know that treatment of the epileptiform activity not only improves the seizure control, but also improves autistic symptoms. Similar findings have been published in tuberous sclerosis complex, in which early treatment of infantile spasms with vigabatrin, very potent anti-seizure medication, may improve the autistic symptoms. Some of the newer generation of anti-seizure medications that are specifically designed for treatment of tuberous sclerosis complex, targeting what's called the mTOR pathway, have been shown to both improve epilepsy and autistic symptoms. What's not clear is whether or not these findings are generalizable to larger groups of patients with autistic spectrum disorder, but this is where current research is ongoing. I'll just touch on a couple of these points, which I've mentioned, some of which I've mentioned already. So, although about 5% of neurotypical children may have epileptiform discharges on their long-term EEG, this number goes up to about 60% in children with autistic spectrum disorder. That means that about 60% of patients who come through our ambulatory video EEG study and get a proper analysis of their EEG will be found to have epileptiform discharges, which may be the basis for treatment, as I've mentioned. There are some interesting differences between the distribution over the head of epileptiform discharges in children, normal children, compared to those with autistic spectrum disorder. As you can see in the right field, this image here on the right side of the screen, there's significantly more spikes over the frontal lobes in patients with autistic spectrum disorder compared to central and parietal regions in patients who do not have a history of either autism or epilepsy. Again, the number of the incidence of these discharges in patients without epilepsy or autism is significantly lower than those who are affected by autism. Most children with autistic spectrum disorder don't actually have a history of seizures at the time that we first study their long-term EEG. So it's very interesting to see sometimes a youngster 2, 3, 4, 7, 8, 9 or older who has no history of seizures but may have a very abnormal EEG. As I mentioned, there is a significant benefit in terms of predicting those children who may go on to develop epilepsy based on the EEG. This study by Verapan, published in 2018, compared 33 children with autistic spectrum disorder who had normal overnight EEGs to 24 children with autistic spectrum disorder who had epileptiform discharges or transients on their EEG. And what they found was if they went back and looked 2 years later, there was a 5-fold increase in epilepsy at 2 years if a child had epileptiform activity on their EEG. So this may give us important information in terms of predicting which children are likely to go on to develop epileptic seizures, and perhaps early initiation of anti-seizure medications to prevent the onset of epilepsy. And finally, I'll touch on treatment. I know that many parents out there are going to be resistant or reluctant to place their children on anti-seizure medications because of a lot of perceived dangerous side effects or risks of them. This is one study that looked at one medication and its use in autism. So levetiracetam, which some of you may know as Keppra, has actually been associated with both a decrease in some of this epileptic activity in the EEG and improved cognition in youngsters with autistic spectrum disorder who had epileptiform transients or discharges on their EEG. So this is, and these are both of these publications that I've mentioned, these are relatively recent, 2017, 2018. There's a number of other ongoing studies, but this at least provides us with some limited data to suggest that that children who have abnormalities, epileptiform abnormalities on an overnight EEG may benefit in two different ways. One in which may benefit from treatment with anti-seizure medication. One is that we may be able to either prevent or delay the onset of clinical seizures. And the second being, we may actually improve their cognitive function with initiation of anti-seizure medications. So this was a very brief kind of summary of why we do what we do in obtaining overnight video EEG studies in youngsters with autism. I hope it was helpful and cleared up some questions that some of you may have. So thanks again for the opportunity to speak with you today. Take care. Bye-bye.